Artificial intelligence systems are showing an increasing promise for numerous healthcare applications. Recently, the advantages of deep learning are spawning artificial intelligence systems with human-like performance in several clinical domains. However, these applications are not designed to capture the variability of personal or subpopulation level of clinicians, such as intern, junior, middle, or senior clinicians. In fact, recent works are highlighting how artificial intelligence and the advancement of technologies together are empowering the aim of personalized and precision medicine. Given the need of personalizing and customizing the artificial intelligence recommendations, an important question in the design of artificial intelligence systems is how they should communicate. Considering the professional experience of the clinician, communication is essential to increase the reliability of an intelligent agent when providing a diagnosis to a clinician. One way to achieve that is by aligning the levels of assertiveness of the agent with the years of experience of the clinician. Besides that, providing an explanation of how and why the assistant achieved a certain output increases trust on the system, solving a problem known as the black box problem. In this paper we present our study for applying breast screening AI framework into conditions where clinicians will interact with conventional and assertiveness-based intelligent agents. The assistant will act as a second reader, resulting in improvements in diagnostic performance by reducing false positives and false negatives, such as the problem of overdiagnosis and underdiagnosis, as well as inefficiency and efficacy in the clinical workflow. While considerable work has focused on improving the accuracy of AI systems, comparatively less work focused on improving adoption and usability of interactive assistance techniques. This paper contributes broadly to the latter by examining what clinicians need when using AI-powered assistants, the practices they adopt while using diagnostic tools, and how these tools affect the end-user attitudes towards the underlying AI systems. Our assertiveness-based agent uses recommendations for classifying and segmenting. 1. The number of detected findings. 2. The patient severity of each breast and per medical imaging modality. 3. The visual scale representing the benign or malign estimates. 4. Providing visualization of the sensitivity and specificity outcomes of the models. And 5. With clinical arguments of the patient such as pathological covariables. Clinicians can open the patient by selecting the in a list of patients. When the patient is open, clinicians can select each respective image of the breast by drag-and-drop each image to the viewports. From here, clinicians can manipulate the image through the toolbox. In the end, the idea is to accept or reject the final recommendation of the AI agent, while clinicians can also ask for an explanation to support their final decision-making. The key difference between the two AI agents was in how they show communication with clinicians. A typical output from an AI model includes not only the predicted classification of the birds, but also a likelihood distribution over all possible classification choices. In our study, both AI agents were designed to communicate this type of quantitative confidence in two ways. One, for the conventional condition, clinicians could simply see the suggested numeric representation of the birds and the respective accuracy of the model. 2. For the assertiveness-based condition, the agent was communicating the clinical arguments, along with the communication of the birds and accuracy, but this time by descriptive information. While our conventional agent employed this basically numeric representation of confidence, our assertiveness-based agent communicating the quantitative confidence based on a descriptive sentence of the clinical arguments. Specifically, the image viewport was augmented with an additional bounding box, or circle ellipse highlighting the lesion characteristics that were likely to explain the final bird's classification. The patient's detailed augmentation for medical imaging on breast cancer diagnosis was extended with an assertiveness-based explanation. With our system, we are listing human interpretable clinical arguments for classification and segmentation recommendations that would adapt their communication, depending on the personalized and customized demographic characteristics of the clinician. These clinical arguments correspond to the classification outputs of an AI model and were trained on data from real-world clinical cases. Our study draws from 52 semi-structured interviews and user testing with clinicians for breast cancer detection via medical imaging diagnosis. Our user studies demonstrated not only the efficacy of the assertiveness-based agents, but also effectiveness in achieving the proper diagnosis of the patient. Clinicians took less time to diagnose a patient with the assertiveness-based agent in comparison to the conventional agent. If explanations are adapted taking into account the medical experience of clinicians, the accuracy chance of correctly diagnosing a patient is higher. Clinicians showed an increase in trust in the assertiveness-based agent, as it was more reliable, understandable, competent, and thoughtful. To summarize, we provide a novel perspective on how to personalize and customize the explanations of intelligent agents to clinicians. We demonstrate that the chance of correctly diagnosing a patient by adapting the explanations, taking into account the medical experience of clinicians, will be higher. Clinicians are showing an increase of trust, preferring the assertiveness-based agent by being more reliable and capable, as this agent was revealing to be further understandable, competent, and thoughtful. Our results from an experimental study with 52 clinicians suggest that the ability of a system to adapt its communication tone has merits for end users. Please follow our paper for more.